Okay, so video 2, I'm going to talk a little bit about inotropes and cardiogenic shock. There's kind of a lot to talk about, so bear with me. I'll try to keep it under like 7 or 8 minutes. So the 2 drugs that we use in the ICU for cardiogenic shock are inotropes. We have milrinone or Primacor, and we also have dobutamine. Both of those are inotrope medications. They work by increasing the contractility of the heart and reducing systemic vascular resistance. So what that means is inotrope increasing the contractility of the heart or increasing the cardiac output. They do that by functioning actually on the heart muscle, but they also function on the smooth muscle throughout the body that causes some vasodilation through the body to help reduce the amount of resistance that the heart is actually pumping against. And so sometimes that's confusing. A lot of times these patients are hypotensive. They're on Levophed, which actually increases the systemic vascular resistance. It really tightens up that aorta. It clamps all your vessels down. But in these particular patients, we want to find a fine balance. And so by increasing the contractility of that heart and relaxing the smooth muscle just a smidge, you can in turn have a higher blood pressure by increasing the cardiac output. So you're really just thinking, what can I do to help the heart? What can I do to help it? And sometimes it's offloading or reducing the amount of afterload by vasodilating the systemic vasculature a little bit to help the heart pump more effectively and get more forward flow through the body. So I hope I explained that as well as I could. It's difficult without pictures and drawings. So what you see in these people is they have poor forward flow. Like their pump is just fat, floppy, weak. It does not get anything out. So they have cold extremities. They have increased lactic acidosis. They are hypotensive. They have sometimes pulmonary edema. Looks like they are kind of wet in the chest. They have sometimes acute kidney injuries. So those are kind of really what they look like. We get an echocardiogram. A lot of times they have reduced ejection fraction. Pretty severe. Sometimes they're coming in, they have an acute exacerbation of cardiogenic shock, whether it's because of a heart injury, it's secondary to stress cardiomyopathy or Takotsubo cardiomyopathy, maybe they have flu, maybe they had an ischemic event. And it also can be chronic. Sometimes patients have chronic congestive heart failure with reduced ejection fraction, ended up having cardiorenal syndrome where they're kind of decompensated and they get really fluid overloaded, and they come in and get some medication and get some IV diuresis during that. So the parameters for these, like I said, you're going to have patients who have low blood pressure or hypotension. A lot of times before we even know they have cardiogenic shock, you're going to have them on Levophed because they're not looking good. So the other thing you're going to see is cardiac index. So if they've hooked up to an A-line, you've got them on a Vigileo, we're going to be looking at the cardiac index. It should be above 2.2 is our idea. And you have to think about, look at your patient as a whole. If you hook that Vigileo up and your index is 2.5 and you've got them on 0.1 of Levophed, it's still not good. So it's still considerably low, looking at kind of everything, big picture. So cardiac index is a measurement that is more specific than cardiac output. It takes into account the patient's size. Because cardiac output is not specific. For somebody who's 5 foot is going to have a different cardiac output than somebody who's 6 foot. So cardiac index is kind of what we use. It's a little bit more, I guess, easier to kind of to gauge. So really important, and something that I learned as a bedside nurse when starting these medications, because in the chart it tells you that titrate for a MAP goal of 65, which is sometimes not helpful because they can cause hypotension. So what I typically did with these patients is, if they're on Levophed, I always ensured that I had a little bit of a cushion. So I would have my Levophed at a dose where my patient was maybe on a systolic of like 100. So had a little bit of a cushion before starting this medication. If I was starting dobutamine, it I always started at half the dose that it is set to titrate at. So if it told me to start at 5, I'm probably going to get in trouble for telling you this. If I talk with you guys, I always tell you to start at half the dose. I always started at 2.5 micrograms per kilogram per minute and gave a solid 15 minutes before I even touched the drug. You have to take into consideration the flow rate in which it's going and the distance it is from the patient. So sometimes the flow rate is only, I don't know, 15 cc's, and the line of tubing may be 8 cc's. So it may take a considerable amount of time to get it there. So more than 5 minutes. Give yourself a solid 15 minutes starting at half the dose. Once the 15 minutes has come up, you see you have no oh shit moments, then you increase it to 5 or your desired dose. You're going to be looking at your cardiac index. Sometimes you don't see an immediate effect. The first place that you're going to see your patient respond is urine output if they're a patient that does not already have necrosis to their kidneys and they can still produce urine. So hourly urine outputs is going to be like the best thing to tell you that your patient's responding. You'll also see decreased lactic acid and your blood pressure will in turn get better in time. Same thing with Primacor. I would start at half the dose. A lot of times when we're ordering these medications, we're not letting them be titratable. I'm not giving it and say, go from 2 to 20 on your dobutamine, because I have seen in the past where a nurse says, okay, it tells me to titrate for a mean systolic or a mean blood pressure of 65, and then they're titrating it all the way up to 20, and it's not really helping the patient. So there is a little bit of strategy in just kind of understanding how the medication works. If your patient does not tolerate it, if they have a rapid decrease in blood pressure, did you start the dose too high? Did they get a bolus of that medication? Did you start with a blood pressure of 80 systolic? Other things is they can increase tachyarrhythmias, so just make sure that you're watching for like PVCs, frequent PVCs, ventricular tachycardias, increase in heart rate, and then also making sure that your electrolytes are on point. So I hope that's clear as mud. It's kind of a hard topic. It's not really easy to go over on video. If you guys have any questions, please let me know.